The Mannin Line with Andy Wint.
Pastor Mike, good afternoon. This is Mannin Line on Manx Radio, 6 minutes after 12, Friday lunchtime. And today with the pharmacist. Well, we used to call them chemists once upon a time, but Nick Kaye is the chairman of the National Pharmacy Association. Long-time pharmacist. He'll tell us more in just a few moments' time, but just want to clarify now where the pharmacist stands in the medical services on the Isle of Man. Had the matrons on the other day, and you've heard many times about appropriate places for treatment. So let's find out about the pharmacist today. Well, Faster Mike, good afternoon. Nick, hi.
Hi, thank you very much, Andy. Thanks for having me on.
No,
Delighted to be here.
Not at all. You are, well, let's get this out of the way first of all. A third-generation community pharmacist, is that right?
Yeah, indeed. Yeah, third generation. There was absolutely no hope for me, Andy. I often start these things saying I should have known better. But, you know, my paternal grandfather, my paternal grandfather, my aunt, my uncle and my brother are all pharmacists as well as my own father. So it really is a family passion and way of life.
Okay, so I mean, apart from the peer pressure of families, what led you into pharmacy? Why did you choose to do it?
Yeah, so I think the thing that I really like about pharmacy is the clues in the title, isn't it? It's community pharmacy, and when it's done well and it's done properly, we really are part of the communities that we serve. We form those relationships with our patients, with the people in there. We're trusted part of healthcare and trusted part of health advice. And also, I did work briefly across in doctor's surgeries, and actually that barrier between having to make an appointment to see you as opposed to in a community pharmacy, anyone can walk in, anyone can have access, and I think that's really important.
Okay, when did this change? When did the community pharmacy, if you like, come of age? Apart from somebody dispensing stuff.
Yeah, no, and I think that's a really fair question. And actually, if I look about the journey that my grandfather, father, and myself, as we all worked in family businesses before, really community pharmacies have always been, I think, a place for trusted advice. You imagine you go in and maybe you would buy something for an over-the-counter ailment, a cough, flu, a cold remedy, but actually at that point you'll get asked questions. Who's it for? What's it for? What's going on? So that point of advice and trust has been there. Maybe the advice that we've been given is changed and evolved throughout the years. I qualified in 1998, and if you'd have said to me then I'd be sticking needles in people's arms, I'd be writing prescriptions, I'd have said you were completely and utterly off your rocker, to be frank. But I think community pharmacy has always been a trusted place for advice. What we do and the functions we have, I think, it evolves as time goes on. And
let's get it straight. I mean, to be a pharmacist, you need more degrees than a thermometer. I mean, you need to know of what you speak, don't you?
Indeed, I think that's really fair. So, currently a pharmacy degree is 5 years, and then again, to do prescribing, which some of the pharmacists go on to do, although all pharmacists actually will be able to write prescriptions from the cohort graduating in 2026. Currently, for me, when I did my prescribing training, additional training about 7 years ago, that was an extra year's course. So 5 years, including a year's of sort of on-the-job training, we call it pre-registration or foundation training, and then a master's degree in being able to prescribe. So again, really highly trained.
Okay, Nick, you've been around for a long time. Why don't people know what medication they're taking?
So I think that's really important, actually, because again, having seen that from the side when I worked in doctor surgeries and within community pharmacies, lots of thing I think is around sort of time. You come in, in medicine we're amazing at starting things, we're awful at stopping things, and actually what happens is you get a result, you get a blood pressure or something, or a high cholesterol reading. You come in, you get told this is your medicine for this is your medicine for that, and actually then the information and stuff afterwards, people sometimes get worried to ask what to do. And the number of conversation I have as a pharmacist is, I didn't want to tell the doctor, but can you remind me what this is for? I think that's just part of the education. And again, let's be really clear, it can be overwhelming. We see people on 7, 8, 10 medication in the morning. To actually remember all of that is really difficult.
So, but it is incumbent on people to kind of realise what it is, to know their, if you like, their amlodipine from their lecanidipine to their losartan. You can tell what I'm on, can't you? So you need to know. And getting things mixed up is no joke.
No, it absolutely isn't. They say, I think there's some data across which, medicine's harm costs billions in healthcare resource, 1.3 billion, I think, which is an NHS England figure of harm that medicines do if you take into account all of the stuff we do. So you're right, we do have a personal responsibility to understand what our medicines are for. We always get taught at university, one of the first things, medicines are really powerful. They change the way our body works, and hopefully that's for positive gain. But actually, the reason we get side effects, the reason that we can get things if the medicines are either taken incorrectly or given for the wrong reason, they are poisons, they can cause harm. So, yes, that personal responsibility is there, but also all the community pharmacies across the island will be able to give great advice if people are struggling. Okay,
so there's knowing what medication you're on and what it's for and when you need to take it and when to stop. Courses of medication, what's your advice?
Yeah, so I think that's one I would say. So some things are really easy to stop, isn't it? You may have antibiotics, important to finish the course so that you don't get resistance. You're taking those for 5 days, but how many of us, think actually my cough's disappeared and actually I'm going to stop it on, 3 days in, and that's not appropriate. We really do need to finish the course. And then the second longer term treatment, maybe, you've been on medication for blood pressure or cholesterol, but maybe you've lost some weight, maybe your diet's changed. So then really that's then a case of going back to whoever started that prescription and going, actually, do I still need to be on this? Because, as I said at the beginning, people are great at starting medicines, but people are inherently nervous about stopping medicines. One of the things I did when I worked in general practice was about the de-prescribing and the stopping of medicines, taking people off high-dose painkillers, taking people off blood pressure medication. And it can be difficult because people are being told, well, somebody I really trust told me I needed this medicine. But actually, to step away from it, sometimes people feel a lot better.
That's really important to know. So is that the decision for the patient to take, or is it in conjunction with the GP? Or
so I think it would be...
People can often feel a comfort blanket, almost a placebo. They're taking pills, so things must be okay.
And it's one of the questions we get asked quite a lot in the community pharmacy. How long do I need to be on this for? Is this something I should continue? Most people that are on what we would say long-term conditions, so whether that's a medication for asthma, for diabetes, for blood pressure, should be getting annual reviews. And the whole point of the review is it's a decision you make with the evidence that your prescriber has in front of you. What are your readings? What are your blood results? And if things are changed, there is that question to ask, and it's the right question to ask. Does the medicine need to go up? Does it need to go down? Do I still need it anymore? But that review process is something you should absolutely do in conjunction with your prescriber.
Okay, we all know. We've heard anecdotally tales about taking ages to get a GP appointment on the Isle of Man. Yeah. So the pharmacists are filling a bigger role now, surely, than they were before.
And again, we see different models of care sort of providing, on the island there's the minor ailment scheme where, people can walk in and get various conditions treated at any of the community pharmacies. Some of the other pharmacies offer a blend between giving the Manx care service first, but then there may be an option for private consultation as well. Some of the place the pharmacy that I work in, we not only would offer you a Manx care first, but, this morning I've already seen people for a private consultation for antibiotics, pain relief, and because we're a prescribing team, then we can write private prescriptions as long as it's safe and appropriate and clinically relevant for that person. But your absolute point is right. Community pharmacy is the heart of its community. It's part of primary care, and as a trusted source of advice, we are plugging that gap. One of my colleagues across described community pharmacy as the shock absorber of the NHS, and I was privileged enough to give evidence in things like the COVID inquiry, the UK COVID inquiry, and that comes through really clearly that systems don't work without the goodwill of community pharmacy colleagues.
Okay, so the minor ailment scheme. So what part of Manx care in that? Do they sanction that? Do they authorise that? How does that work?
Yeah, so the minor ailment scheme is something that Manx Care pays for. They value community pharmacy's time, so there's a list of conditions where you can get seen in a community pharmacy, and then under something called a patient group direction, you may be able to get medicines that would normally be given on prescription through those community pharmacies. So those lists are available on website, but the type of things is some conjunctivitis, impetigo, urinary tract infections in women, hay fever, thrush, gout. There's a list of conditions where people can access that.
Okay, I've got it in front of me. Bacterial conjunctivitis, inflammatory skin disorders, impetigo, cystitis, shingles, vaginal thrush, oral thrush, hay fever, coughs, gout, exercise-related injury, toothache, constipation, and nappy rash.
Yes.
Well, there's a day's work.
More than for most of us, yeah. No, and again, it just shows the type of varied stuff, and that list is built on from probably the evidence that is actually things that pharmacists are already seeing, and things that people want to access and get care for. I mean, all the evidence is showing as well that people are expecting community pharmacies to do more of this and actually are really happy to receive this care in community pharmacies, and that's important.
That's interesting. The bank care have said, can you do this? Are the pharmacists happy to do it? Yeah,
I think we are happy to do it, and not only are we happy to do it, I think if the investment is there, we would be happy to do more. And I think it's about where you look, and in my privileged role on the National Pharmacy Association board, I see different systems in different states of development. So, in Scotland, you can get 20, 30 prescriptions prescribed. They pay for pharmacies to have an independent prescriber in, so if something doesn't fit within that list, other care is given. England only has 7 conditions. Wales is up to about 12 or 15. The Isle of Man is in this uniquely and privileged place that it should be able to cherry pick from the best of the best and then implement it. You've got willing pharmacy contractors to be able to build on that care.
Okay, just one thing I want to ask about, and Nick's mentioned this to me before, and it made me giggle. You were in, I think, Cornwall, which of course is your sort of a place you come from.
Yeah.
But what happened after COVID? You mentioned something about teenagers after COVID.
Yeah, so this was really interesting. I was working in a pharmacy and in a doctor's surgery, and just after some of the restrictions had lifted off one of the first lockdowns, what we were doing was we were looking and we're saying, why are we seeing so many young people with constipation? Really unusually, not something that we would normally think, people really sort of struggling and all that kind of stuff. And then on my way home, because I was, working actually in one town and living in another, I noticed that McDonald's was open. And the queue was around the car park. And we actually started to ask the people what they'd been eating or change of diet. And when we went back and looked at some of the notes, it was McDonald's fault was a lot of the constipation. So I just found it absolutely fascinating that the link between the fast food and then what we were seeing.
They've been eating healthy during COVID, and then they started on fast food.
Exactly right.
And they got constipation.
Exactly right.
A question for the pharmacist, says Jane. In the view of what's happening in the UK and here regarding assisted dying, what's the view of the pharmacist governing body in the dispensing of drugs?
Yes.
I'm not asking for his personal view on assisted dying, just the governing body.
Yeah, so that's really important actually, and really, really timely. So the governing body for community pharmacy is the General Pharmaceutical Council. That sets our regulatory body. But the one I sit on is the National Pharmacy Association, which has all of the, represents all independent community pharmacies on the Isle of Man and across all 4 nations. And the listener will be pleased to know, and I'd be happy to feed back. Our next board meeting is in June, and the board is considering the official position of the National Pharmacy Association in June. I do have a personal view. However, if we're asking for the regulatory or the national body's view, I'd be happy to feed that back after June, Andy.
Okay, remember, we're with the pharmacist today, Nick Kaye. So we're not giving clinical advice. It's not about that. We're just trying to find out where the pharmacist fits in on all this. And I knew this was going to happen. Fred on 807 said, could you ask Nick his views on medicinal cannabis?
Yeah, no problem. So my view on medicinal cannabis, so, we are one of 3 pharmacies on the Isle of Man that can dispense medicinal cannabis. So I have seen it work exceptionally well for people. I've seen people come off other medication. I do think it has to be prescribed appropriately, clinically safely. I see it as a very safe medicine in general terms, and I have seen some really interesting benefits from it. I think the sort of political history with cannabis has given it a bad rap, for want of a better description. However, it needs to be, like I say, prescribed in the right way, the right advice given with it. And what I really like about most of the pharmacies on the island that dispense cannabis is we're not just cannabis pharmacies. So my view on this is cannabis is an adjunct to holistic care as opposed to being the only treatment people should be seeking. So we view it as part of a holistic package of treatment.
Nick, how does it work? How does medicinal cannabis work?
Yeah, so it's a really complicated question, actually. So medicinal cannabis has got people would think about two types of main ingredients in there. So you'll hear about CBD and also THC. So the cannabinoids in CBD is less restricted. You'll be able to buy that from other places. It's classed actually as a novel food product. And then you think about things with THC in it. Now, those THCs are the things that actually give the effects that, maybe relaxing, some of the sort of, other effects that you might get to do with sort of pain relief and some of those other things. And actually, a good medicine is actually balanced with both. So, the CBD obviously offsetting some of those drowsy things that the THC would cause. In crude terms, it helps with, pain, anxiety, worry, and is really works on the receptors that deals with those type of issues. Oddly as well, I must say, we did have somebody who admitted to me that they were using, because some people say to me about CBD and, well, that hasn't got the good stuff in, that's only a placebo. However, we have had somebody come in who admitted to me that they were using CBD on their dog, not with our advice. However, their retriever's arthritis has disappeared on the CBD. Now, you can't placebo a retriever. So my mind is constantly being changed and challenged on the role of both medical cannabis and CBD, but it does fit in within a profile.
As you say, because of cannabis's reputation, since, crikey, musicians have been smoking it since the 1920s.
Indeed.
So, where, if you like, as a society, the Western world is trying to find its way around cannabis. Do you think we're coming to a conclusion where this is concerned?
I think it will take time, and one of the things that we've done with, I've done personally as well, and our team do, is the training around that sort of medical cannabis. I mean, I don't think many of people that realise that they live in Hertfordshire are actually, in Hampshire, are actually in Hampshire, because back in Henry VIII's day, he decreed that so much of the British Empire had to grow cannabis because of the hemp for the bags and the medicinal value of the product. So, and then it's sort of been politicised throughout the 20th century, which has given it where it's ended up now. So, it's a medicine that's been around for hundreds of thousands of years, and I think we're grappling now with the destigmatisation of cannabis. And actually, the stigmatisation around cannabis probably stops it being regulated in a slightly different way and stops it being so mainstream. Like I say, I think we're battling with that, and I think it will get more and more acceptable is probably the wrong word as time moves forward. Commonplace is a really good word, Andy.
Yeah. Jenny just dropped a note in just to say, as somebody who uses medicinal cannabis, I can say that it's taken my pain 90% away. And Jenny's allowed me to say that she was suffering with Crohn's disease and took a basket full of medications, and suddenly this has helped. Now, without it sounding like a miracle cure, it seems to be doing rather well.
Yeah, no, and I would agree, and that is replicated across lots of people that we see. We've had people that have come in with certain personal stories of not now taking really strong painkillers. You'd have heard in the product the fentanyl, the oxycodone, really, really powerful painkillers with lots of side effects and lots of actually addiction potential, and replacing that with cannabis, which is much kinder to the system. Jenny's story isn't unfamiliar, and I think that's where my mind has really been changed on it as, like I say, pharmacist since 1998 and a prescriber for the last 7-8 years. Actually, those positive people stories are really important and should shape our thinking, but it has to be done in the right way for the right people. Jenny's case, obviously Crohn's disease, defined stuff, reduced her medicine load, absolutely perfect prescribing and fantastic.
And just coming back to painkillers, obviously over-the-counter painkillers have been around for a lot. I mean, there's a German guy invented paracetamol, didn't he? Aspirin's been around forever, salicylic acid. We've got ibuprofen now as well, and we've got some really powerful painkillers. Addiction to painkillers is legendary almost. How can that be mitigated, Nick?
Yeah, so it is really difficult, Andy. I've been in pharmacies before where the common one was Nurofen Plus, which is ibuprofen, which isn't addictive, but obviously the codeine element to that is the real problem. You'll see lots of things on the label saying now, do not take for more than 3 days. But, people may struggle to access healthcare advice from other professionals within that time and be in pain. So obviously get that right assessment. mean, the other thing as well to recognise is, I've had somebody, like I say, that was coming in and they admitted to me they were actually spending nearly £1,000 a month on Nurofen Plus from various different pharmacies, and came into me for a consultation. I said, I can't sell you this box, you were in yesterday. And they actually, we went into the consultation room and they actually broke down and said, I mean, their kidneys would have been smashed apart because of the ibuprofen, which is, it was just really, really painful. Stomach would have been ruined. And we actually helped them realise what they were doing. They opened up, they seek some advice, and actually they, the addiction to over-the-counter painkillers needs to be treated and managed in the same tactful and mindful way as any other addiction. But to your question, how can it be mitigated? Get the right advice. Make sure we're taking it for a pain that we know and that we know is why diagnosed. Some of the problems with, withdrawing things like, things with codeine in, actually, if you've been taking it for a headache, when you stop the codeine, the headache can come back. Is that a withdrawal or is that the original symptom? So it's just about unpicking that and getting the advice. And like I say, in my previous world, having titrated people off things like pregabalin and oxycodone when working in a general practice setting, the change of life as people come off the painkillers at the end of it is amazing to see, and hard to get there, but amazing to see.
Chronic pain, though, is debilitating,
completely
depressing.
Yep.
It blights people's life. So, as you say, how will somebody know that they need to reduce their painkillers but not get, if you like, the withdrawal symptoms, and as you say, get withdrawal symptoms mixed up with the original problem?
Yeah, so the way in which you do it is, a rough rule of thumb would be you'd always do a reduction of around 10% at a time. So when I was doing reductions of medicines, people on a high dose sort of morphines and things, or any type of painkiller, if you take a rule of a reduction of 10% should be enough. And what you find is that people then get frustrated with how quickly it goes, because at the beginning they're dropping quite quickly, and as they get to the end it takes much longer. But it really is that kind of rule of 10%. And your healthcare advisor, your pharmacist, your GP nurse will be able to help you with what that looks like. Do I need to change the form? Do I need a liquid? What does that look like? But it's really is about slow and steady. And the other thing as well is, people obviously get into these things, as you say, and it doesn't cross their mind that maybe we should try a reduction. Do I still need that? So a lot of it is being out in the right headspace to actually start that reduction. But there's help out there for people that want to do that. But overridingly, slow and steady, a rule of 10% is my rule of thumb when I've done it before. And just give people the support. Also, don't set yourself up to fail. Don't go, I need to be off this by a week next Thursday. As you come through, different things will happen. As long as you're going in the overall right direction, that's okay. Or if the pain comes back and we recognise that, then actually maybe this is the dose we need to be at.
Okay, let's get to the lines now. Oh, Julian's on with us now. Hi, Julian. You're live with Nick Kaye.
Hi, Andy, and hi, Nick.
Hi, Julian.
Hiya. Just wondering, are you concerned that vitamin D levels are not routinely checked by the health service in the general population, which may actually ameliorate a lot of the prescriptions that have to go out?
So great question, and like you say, a really big topic at the minute. Vitamin D is there. In our business, we've taken on lots of care homes, and the amount of vitamin D that goes out is a lot. And like that, most of those started from blood tests. But adding it into a routine screen doesn't seem unreasonable. I think is a reasonable thing to do and to request. Obviously, I don't decide the testing guidelines, but I think as a suggestion, absolutely seems reasonable and fair.
Yeah. Have you noticed actually an uptick in vitamin D prescriptions since 2020 when more people have looked into it?
Yeah, very much so. Yeah, absolutely. So working both here and across, absolutely both. There are an increase in regular prescriptions, high dose loading prescriptions, and then people coming off it. So yeah, I don't have the data immediately, but my gut result is absolutely since 2020, last 5-6 years, a massive increase in the amount that's prescribed. Yeah.
Great. Oh, thank you very much.
No problem, Julian.
I appreciate it. Thanks, Julian. Now, stopping medications is a message in from Phil, who just said, appointments are time limited, and we're told that doctors can only deal with one issue when you see them. In 30 years I've lived on the Isle of Man, I've never been called in for a yearly health check. How commonplace are these in the UK?
So what you tend to find is, if it depends on the medicine or the condition that you're being treated. So most people who are on things like blood pressure medication, diabetes medication, asthma inhalers normally get an annual blood test, and then there would be an annual review. Sometimes give impressions on systems. Sometimes the annual review is, are things safe? So actually, is the blood pressure okay? Are the blood tests all right? Are the liver and kidneys working okay? Is the cholesterol within normal parameters? And if the answer is yes, then quite rightly, the normal thing is, well, let's review it for another 12 months. But I know there are pharmacists that work on the island that work in doctors' surgeries. You can ask your community pharmacist for advice, but that, if you want a review, that is something that you should ask for. I think I would say routinely, if there's a problem that shows on those annual tests, then you would normally be called. If there's not a problem, given that you've got a focus resource on where it is, then that would normally be continued for another 12 months, 6 months, whatever is the appropriate time interval for that medication.
Okay. Is it true that pharmacists aren't allowed to offer treatments to people aged over 70? Is that right?
So it depends. So I think that's a really interesting question. So on some of the minor ailments that we talked about, Andy, there will be limits on that. So one of them, for example, is urinary tract infection and in women, and there's an upper age limit for that. So again, that's defined on what we call a patient group direction. If you're an independent prescriber like myself, you can, and lots of other pharmacists on the island, then what you can do with that is you can then say, make that assessment and then write a prescription for that. So that's something that I've done while I've been here on the island. Somebody's coming in, just dropped outside of the age for the Manx care system and said, well, you can either go to GP, wait, or we can treat you privately, and then we take that clinical decision together, and if appropriate, we write the prescription for them. So it depends which service you're engaged with for the age limit. So as an independent prescriber, I've got no problem prescribing if it's safe and competent, safe and appropriate. The patient group directions, those list of medications you read out, they may have certain age limits around them.
Okay, Colin just said, we're at that time of year which makes my life hell. It is hay fever.
Yes.
Where do you stand on hay fever? What does a pharmacist recommend?
So it's really, really interesting, actually. So hay fever. So the hay fever, there are medicines out there, and obviously with your prescriber and all that kind of stuff, I would have a look at it. There's lots available over the counter. There's lots of good medications over the counter. There's also a really safe tolerance limit on them. So we sometimes use things that are slightly off license. We maybe increase people's doses with their consent, making sure that the symptoms are well controlled, warning about drowsiness. We've had quite a few requests into the pharmacy that we're working in the Isle of Man, which is talking about Kenalog injections, because they know that we are prescribers and we could prescribe the hay fever steroid injection. But again, there's been lots of data which shows that that's actually probably unsafe for hay fever. So at the minute, we don't feel that is clinically appropriate. So standard treatment, lots of flex in it, lots of things to do with it. The steroid injections, probably the risk is much worse than the treatment. So I don't think you'll find many clinicians offering the Kenalog or steroid injections for hay fever at the minute.
Is there something called omeprazole?
Omeprazole, yeah.
Omeprazole. I've been on it for years, and I believe it's not good. How can I get off omeprazole? Daphne,
great question. So omeprazole, people may remember it as a trade name of Losec. It helps with stomach acid, and it was the widely prescribed drug on, for years for volume. More people on that than anything else. What it does is it turns down the production of the acid in the stomach, but what it does at the same time is it can knock out different sort of ways in which we absorb other sort of vitamins and minerals, maybe iron and sodium, that kind of stuff. We always used to say you had to take omeprazole every day, and obviously Daphne will need to check with a clinician, but now when we're giving advice on some of that, whether we stop it, the answer would be, you don't necessarily need to take it every day. Take it if you get symptoms. Is there a period you can have without it? And go from there. That will give you a rough idea of knowing whether or not the symptom is still required, the symptom still needs treating, or whether actually you can do with a couple of days off. But Daphne really needs to do that with discussing with her prescriber. But that's what we'd say. Maybe don't take every day.
Okay, thank you, Ted. This is, let me see. My husband has complex needs. He takes 120 pills per week. We're elderly, but we can't get to the pharmacy to put it in a tray because they closed the waiting list for trays 2 years ago. What do we do?
There are pharmacies that still offer trays. I'll say that with a smile on my face because we're not supposed to be obviously commercially plugging, but I'm sure there'll be pharmacies out there that can do that for her.
Okay, and more messages. Thank you for telling me all your ailments today. I'm very impressed, very impressed by all this. You've been doing this for how long, Nick, now?
So I've been qualified since 1998. I'm 50 this year, and I started stacking shelves in my grandfather and father's pharmacy when I was 12 for my first hourly rate of 25p. And my current directors probably keep me on around the same sort of rate, Andy.
Well, We're with Nick Kaye here, a pharmacist. As I say, he's chairman of the National Pharmacy Association and a working pharmacist on the Isle of Man today. And lots more to get back to. More questions in a few moments' time.
Hi Liz, I see you've had your garage converted. We're desperate for more room.
Yes, come through and have a look. John called Manx Property Conversions. We now have an extra bedroom, but it could be another reception room, kids' playroom or office. They also did our conservatory roof last year. We were so impressed, we got them back to convert the garage.
Wow, I need that. What's their number again?
Call MPC on 450 500. That's 450 500. Or find them on Facebook at Manx Property Conversions.
Loganair says, let the wee ones fly. Kids aged 11 and under go fare free this summer. Just pay the taxes. Book by the 25th of May for travel from the 1st of June 2025. Find deals at loganair.co.uk. T's and C's apply, subject to availability. Children must travel with a full fare-paying accompanying adult.
Manx Petroleum isn't just here for motorists, homeowners and businesses. We're here to help good causes too. Because for every time you fill up your vehicle in May and June, we'll fill the funds of the Rob Vine Fund, a voluntary charity that provides outstanding medical rescue care, equipment and training throughout most of the island's motorsport events. Just fill up with super unleaded and we'll make a cash donation for every litre. Find out more and make a donation at robvinefund.im.
Parker and Snell Company proudly presents Alan Bennett Talking Heads at the Gaiety Theatre from the 22nd to the 24th of May. Get ready for a hilarious, heartwarming and unforgettable night of stories that are as laugh out loud funny as they are deeply moving, with an evening at the theatre that will leave you laughing, talking and wanting more. Don't miss Alan Bennett's Talking Heads. Tickets available at villagaiety.com, the Welcome Centre or call 600 555. Supported by your nation station, Manx Radio.
The latest edition of Manx Radio's Breath Mindfulness podcast with Karen Hardman is available now.
You never need to worry about being fed up, not stimulated or instantly happy. That's okay to feel like that.
The Breath podcast, Spectacular Decision Making with Karen, is available now at manxradio.com.
Your body will let you know what you need to do.
Brought to you by the Good Health Store on Station Road in Port Erin.
The Mannin Line with Andy Wint.
Nick Kaye's here. We're talking about the pharmacist, your relationship with the pharmacist, and how the role is changing. Robert's on now. Hi, Robert.
Hi, I'd like to talk to the pharmacist. Is that okay?
Yeah, he's on live with you now. This is Nick. This is Robert.
Hi, Robert.
Hi, Nick. How are you?
I'm all right. Thank you for asking.
Okay, so basically, I'm on medication at the moment for my political beliefs. I'm a Republican in a unionist area.
Yes.
And I'm being chastised by the mental health for having political beliefs. I'm not averting my political beliefs. I keep them to myself quite a lot, and they come out now and again. But I mean, you can't change the blood in your veins. I'm just wondering why the mental health are so overzealous with the medication.
Yeah, so I think that's a really great question. What I would say is, obviously, if you're worried about the prescription and the prescriptions that you're getting and the medication that you're receiving, then that's obviously something to take up with your clinical team. Do you find the medication beneficial?
It's just a sedative, to be honest with you, between you and me, Nick.
Yeah.
It doesn't really help the situation. It's more of kind of like you might as well ingest water into my veins. It's not doing that much. It's a depot medication now and again.
Yeah.
It doesn't really do that much for me. And I usually go for KFC afterwards just to relax. Sometimes I need a bit of a lie down.
Yeah.
But I mean, it doesn't really do anything in terms of like actually changing my perspective or anything. I find that mental health just seems to be a bit of a sticking plaster. They don't tend to do much in terms of things because they know you're not going to change, and they're just dealing with the people in the the upscotch of it or whatever that just will never change and won't be able to get a job and what have you.
Okay.
So I mean, there's no real change there really.
Okay,
No.
Robert. I mean, this is important. We're talking about mental health now,
Yeah,
Nick.
we are. And again, I think what Robert's picked up on exactly is that actually medication is only one part of a mental health treatment package. We all need to recognise that. And actually, I think Robert needs to maybe talk with his clinical team about the prescribing and the options that he's got available to him, but understanding that actually medication is is only one part of that sort of wraparound care.
Okay, Robert. I mean that's the key point here. You must keep talking to any clinicians that are there with you. I mean, you may not perceive that you may perceive that they're wanting to do you harm, but I'm sure they're not, Robert. I'm sure they've got your best interests at heart.
They don't want to do me harm. No one wants to do anyone harm because that's not within the budget. But I mean, in terms of like the actual helping the situation and changing your political beliefs, it's not really within their mandate. And they're just not going to change anything. I'm not going to change. I say what I do and I do what I say. So, that's never going to change.
Okay, all right. We appreciate it, Robert. And again, we've talked about the pharmacist and the role of the pharmacist. What part does the pharmacist play in mental health?
Yeah. So I think this is something that's really important. Actually, as a pharmacist, you maybe wouldn't, listeners may not expect this, but as an accessible part of healthcare, over my time, I've had people that have come in to me and said, how many paracetamol tablets will it take to kill me? How long will it take for me to die if I stop taking my medicines? I had one lady who came in.
Seriously?
Yeah, seriously. Yeah, I had somebody that came in to say to me about an infection on her toe, but actually it was really clear to see within about 30 seconds she was really suffering from really bad postnatal depression. So you would be surprised how much comes into a pharmacy, genuinely, which puts you in a situation where you need to make sure that you can deal with that as a healthcare professional, which pharmacy colleagues absolutely can, and then get the person to the right part of the healthcare team. And that may be because they've maybe struggled for access, everybody's busy, so other parts of the system may not have realised quite how important it is. And great working relationships between community pharmacy and other parts of healthcare is absolutely vitally important for catching that kind of stuff. And when those people have told you those things once or twice, some of those were a while ago, they don't leave you. I'm proud to say that all of those people in that case, we filtered into the right part of the system and the right part of care. But yeah, because there is no appointment, because you can be seen by a highly trained healthcare professional really quickly, you'd be more surprised the type of stuff we see.
Shingles.
Indeed.
And this is let me see, it is Tammy, talking about shingles and the fact that is there more shingles around than there used to be?
Yeah.
Or is it?
Sorry, go on.
Or is that just anecdotal? Are more people talking about shingles?
Yeah, no, so I think more people are talking about shingles because of basically shingle vaccination and where it drops and where it doesn't drop. So the treatment for shingles has been around for a while. It's the same sort of treatment as for cold sore or herpes, same virus, and chickenpox. But actually, there's now shingles vaccines, and some people qualify for that, some people don't. So, oddly again, in Kingsley, we can give private shingles vaccines as could other pharmacies on the island. But actually, some people qualify under Manx care. So more people are talking about shingles because actually, maybe they don't fit the national health criteria, they don't hit the Manx criteria. How can they get it? Is there supply on the island? So we've definitely had inquiries about shingles vaccines and how to give it. They're not cheap, but people do want them, and we do administer them.
This is Maxine who just said, Nick talked about, did you say listen to your body or listen to what your body says earlier on? Yeah. How do you listen to your body?
How do you listen to your body? I think that's a great question. So I've actually done some stuff about internal perception, which is fascinating. So actually there's a whole thing about whether or not how much you should do that, because there's a study with people with cardiac arrhythmias or funny heartbeats where actually if you tell them to watch out for that, they didn't know they had a funny heartbeat, and then as soon as you tell them, they're frightened to go out and frightened to do anything and frightened to be there. So internal perception is actually a growing part of medicine, and things that we add to care. I think we know sometimes about our body. Do I need to do that? Am I aching? Should I have had 7 curries? What does that look like? How's my pain today? It's just being about a bit more honest with yourself.
How do you recognise the signs, though?
How do you recognise the signs? So I think it depends on what sort of condition you're sort of thinking about. So with pain relief, have I ever done it? Have I picked up the kids, the grandkids? Was that round of golf appropriate? They're quite easy to perceive. The trouble with some of these things is they come up over time. So it's that reflection back about maybe what you could and couldn't do in the past. And then as far as symptoms is concerned, we talked about the lady originally with omeprazole, that sense check and that challenge. Do I need that medicine? Do I not? How does that look? Done with your healthcare team.
Now, what's happened in the past few years, suddenly weight loss jabs have come out of nowhere. Have they come out of nowhere, or have they been around forever?
No, they've been around for a while. So, I mean, this is something that we do quite a lot of. Really proud of the way in which we do it. I think there's a right thing to say is that, the medicines have been around for probably 20 years. And, and if you look at the history of that, designed for type 2 diabetes, people lost weight, type 2 diabetes, they then came off the type 2 diabetes medicine. And pharmacy was like, pharmaceutical industry was, I think we'll market to the side effects. What are they doing? So, obviously there's a unique way in which they work. They've been around for a little while. Obviously a big uptake in sort of the private market and things now. I think it's really right and important to say how to do those consultations properly. So in the NPA, my vice chair Olivier has been on dispatches. We've helped, advise the General Pharmaceutical Company, General Pharmaceutical Council about the right way in which you should do a weight loss consultation. That either face-to-face or video consultation, not just a tick box, not just an appropriate thing. I think, I have, and we do on the Isle of Man in our clinics, refuse people that are inappropriate and trying to give them the right advice. I think it's really right and appropriate to do it safely. I do think as well, though, it's one of the most without wanting to sound believing into the hype too much, one of the most amazing things that I see. I've seen people over the last year, drop a significant amount of weight, stop medical cannabis, stop diabetes medication, reverse type 2 diabetes, come off their painkillers. It's fascinating, and I am going to say there's one lady that left me with a really powerful story. She said to me that the weight loss jabs are the difference between can't and want. And I said, I don't understand. Explain that to me. She said, well, when my partner comes home and with a takeaway, if I'm on Weight Watchers diet, I can't have this medicine. When I'm on the injection, I don't want the medicine. It's the first thing I've ever done. I don't feel like I'm punishing myself. And there's so much in that sentence, Andy, which we could probably fill a whole programme with.
So tell me, what are the Wegovy I've heard of? What are they?
So what you'll see is you'll hear Wegovy, Ozempic and Mounjaro as the names you'll hear. Ozempic and Wegovy are actually the same medication. They were the originator molecule, the first ones on the market, and Ozempic and Wegovy are, like I say, the same. Wegovy marketed for weight loss, Ozempic marketed for diabetes. And then the other one is Mounjaro. We tend to use and see more Mounjaro in our clinics because it you lose weight a little bit quicker, and people don't tend to cycle up the dosing regime as fast. But both do work, and they work primarily by making you think about food less often, helping your body use sugar in a more efficient way, which was the type 2 diabetes part, and then they basically slow the way in which food moves through your tummy, so you feel fuller quicker. They're not appropriate for everyone, but in the people that we are prescribing them to, and we are prescribing a lot, they work.
Are they
the majority of the safe?
Are they safe, Nick?
Yeah, no, that's a really great question, Andy. And if you look at it actually back, these medicines were designed for long-term treatment for type 2 diabetes. And there are some side effects that you get quite commonly, some nausea, some constipation, some headache, some heartburn, which we can help manage. The one really serious side effect that we do worry about is acute pancreatitis. So anything that ends in itis in medicine is inflammation. So whether that's tendinitis, tonsillitis, appendicitis. Pancreatitis is your pancreas is your organ that it produces insulin, and in some people that take the medicine, it can get inflamed, it can get angry. There is no treatment for it. It's stop the medicine. It's nobles for a week on painkillers, but the incidence is relatively small. So for Wegovy, it's around 10 to 12 in 100,000 people. For Mounjaro, it's sort of 50 to 52 in 100,000 people. So I've only actually ever seen it once when I was prescribing across, when the injections were a daily injection, not a weekly injection. And I said to the gent, how are you getting on? He said, fine, but I spent 3 days in Royal Cornwall Hospital Trusts with acute pancreatitis. Can I have my next pen, please? I was like, no, this isn't for you, sir. So it didn't even put him off, but we have to make people aware of those.
And also, regarding weight loss, we've all seen the horror stories of the equivalent of Tupperware parties where people are doing this sort of stuff. Yeah. In what circumstances, what environment should weight loss jabs be administered?
Yeah, so again, we would go back, and I'd be really proud of the way in which the National Pharmacy Association, and I'll being too arrogant myself, and my board have helped direct and shape some of that guidance. We would implore people to get them in from a clinical setting. Make sure your healthcare professional is giving you the right advice. Make sure the product is well labelled, UK based. All those things that are there. You don't want to be buying stuff that you don't know where it's come from. I mean, I had somebody come in to me with a vial and some needles to say they'd bought some stuff online. They don't even make the medicines in vials for a European market. So I think they probably had insulin in there. they would have probably killed themselves if they'd injected it in the wrong way. So, just keep that trusted source. Make sure you're comfortable and happy with the clinical team that you've got delivering that care for you.
Okay, and on that same vein, regarding all medications and treatments, if you like, there is a wild west out there on the internet.
There is.
What's your advice?
So again, I mean, if you're looking at the website, make sure it's registered, do some due diligence. Online is right for some people, and there are ways in which you can do online properly. I would always seek advice and do some due diligence on it. Don't be fooled by clickbait. Don't be fooled with this. Don't be fooled with that. Go back to the General Pharmaceutical Council or the Isle of Man registry. Is the pharmacy registered? Is it appropriate? Have a look, see who the superintendent is, and make sure it's all done properly, safely and appropriately, and make sure they're registered in the right place. Most websites should have an online logo which says that they're registered, but do double check it against the General Pharmaceutical or the Manx Care list or the Department of Health list in the Isle of Man.
Okay, Juan. Hello, Juan. You're live with Nick Kaye. Juan?
I get an irregular heartbeat when I break into a £20 note. I don't know about you, Andy.
No, well, I'm lucky to get a £20 note,
Good job you're not on Manx Care rates as well. How are you, Nick?
Indeed. Thanks, Stuart. Nice to meet you.
Question for you. You were talking there with Julian about the benefits of D&D free and the increase on that in the last 5 years.
Yeah.
And there's been a lot of studies done on the benefits of high potency D3 with COVID and also cancer with shrinkage of tumours. I think there was 105 clinical studies on 200,000 people. What I wanted to ask you was, we're travelling an awful lot during the COVID period. A lot of Mexico and Africa used a substance called ivermectin, which I'm sure you know of. It's also called Ivercare. Now, interestingly enough, they had very good results, which really didn't get into the international press. And I was very interested. The United States, pre-vaccination, cleared the shelves of ivermectin and didn't use it. And I'm just wondering, looking at the test that's now done, what your views are on ivermectin in association with treating COVID and also cancers.
Yeah, thank you very much for that. So ivermectin is obviously medicine that is relatively new and, like you say, was cleared out. There is some stuff with getting it. I would have to go back and have a look at some of that data and look at some of those things before giving any specific advice or opinion on that. As you say, ivermectin is used for various different conditions, and I think I'd have a look at that for you and get back to you if that's okay, rather than give you inappropriate advice online.
Yeah, absolutely. And I mean, it has been around for a while. I mean, obviously people are going to come on and say it's a horse-worming drug, but it was actually repurposed for animals, but before it was repurposed from humans into animals and then repurposed back again. So,
and again, we tend to use ivermectin orally when things like scabies treatments and stuff aren't in stock. Like you say, that sort of, that sort of a traditional use, as you would say, is one of the things that you see. The treatments for things like, like I say, the scabies, the topical treatments went out of stock for quite a long time, and we were using it for that type of stuff. But I can certainly do some research and go back and see where that goes in with the vitamin D stuff. Absolutely happy to.
Okay. All right, Joe.
Brilliant. Cheers, Nick.
Good. Thanks for that. It's 8 minutes now before 1 with Nick Kaye, the National Chair of the National Pharmacy Association, and works at Balfame with Kingsleys. Let's talk about children. And
I have 5. Is that why you said that?
Yeah, so in that case, you're fully. What part does the pharmacist play in paediatric medicine and looking after children?
So do you know what? I think this is really important. So I mean, lots of things that you see now about new advice for healthcare systems is about continuity of care. Actually community pharmacies, we deal with people throughout every stage of life, from, giving people their first Calpol prescription post-vaccination, their first vaccinations, all the way through into old age. I think community pharmacies are absolutely well placed as a first point of care for paediatric advice. A lot of time people need reassurance and need advice, and what community pharmacies are exceptionally good at is saying, I can help you with this, or you need to go somewhere else. So that's something that I'm really proud of what we do. Okay, if you've got a funny rash and you press it goes white, that's a blancing rash, that's probably not so serious, but treat with some Calpol, or actually that's not changing, that could be something different, you need to go somewhere else. So I think community pharmacies have an armoury of things, both on the minor ailment scheme, as you've seen from nappy rash, to over-the-counter medicines like Calpol. But what we are really good for clinical advice is going, that's important or that isn't.
And regarding parents then, just tell me, how incumbent is it on the parents to get to know the pharmacist, if you like? How much should the parent know, and how much should the parent hand over to the pharmacist and the GP?
Yeah, so I think there is that whole thing around, being able to have ownership of your healthcare and the care of the people that you are entrusted to look out for. I think actually good relationships with all your healthcare professionals is really important, and also being able to challenge and ask questions and ask why. And I think that's something that we see more of now, which is right. Why am I giving Calpol after this? How long should I do that for? What's the reason for that? So I'm a big believer in shared decision making. So I often say in my consultations, this may be unusual, but I'm going to ask you, I'm not going to tell you, because I've been a patient too many times and I've been told. And I think I prefer to be asked. And if we do that in that way, I think, pharmacists can be a great place of parents getting advice for their children.
Okay, we're nearly out of time, so I'll just ask you, will you pop back later on this year?
I'd love to, Andy. Yeah, thank you for having me on.
Because I say that because I've got 2 questions on herbal medicines and natural remedies. So give us 30 seconds, and later on the year we'll talk about them. Yeah.
So I think herbal medicines and natural medicines have an absolute place. If you look at some of the things we've already mentioned, aspirin from salicylic acid from willow tree bark, digoxin from foxglove. Herbal medicines are treated as food products. They should be made to the right pharmaceutical standard. Can absolutely help. But I think I would always say if the advice is sometimes the data isn't always that great with them. What I normally say to people, whatever it is, try it. Give it a good try. Give it a try for 6 or 8 weeks. If it's not going to cause you any harm, make sure with a clinician it's not going to do you any harm, and then assess to see whether or not it's going to help. If not, stop.
Okay, remember the minor ailment scheme is available. Pharmacists will be able to help you, and Nick is one of them. Nick from Kingsley at Balthay. Thanks for being with us today.
Thank you, really enjoyed it, Andy.
Appreciate it. Next week on Mannin Line, in fact, a week today, Douglas City Councillor David Cretney is on. And the week after that, the leader of Douglas City Council, Devon Watson. If you want to leave a message, by the way, the answer phone is on 682 631. You can email manninline@manxradio.com. That's it. Thanks to Chris on the phones today. It's a gorgeous day today. It's going to be the same tomorrow and Monday and hopefully all next week. So make the most of your weekend. And thanks for being with Mannin Line today.
WIN